orbital, supraorbital, or temporal area, which are accompanied by many autonomic symptoms such as ptosis, meiosis, lacrimation, conjunctival injection, rhinorrhea, or nasal congestion. A single attack lasts from 15 to 180 minutes, and patient may have up to 8 attacks a day. In the episodic form, which is the most common form of cluster headache, attacks occur daily for some weeks, followed by a period of remission. And the period of attacks is called cluster. And how should we treat? How may we treat a cluster headache? We may use in the acute settings. We start with oxygen. Then we may give drugs typically used in migraines or triptans, other drugs, lidocaine, ergots, or others. And the most in acute situation, the most successful is oxygen. Some time ago, we had a patient who came to our emergency department with a cluster headache with ptosis, meiosis, and lacrimation on the ipsilateral side, and instead of seeing a doctor, he wanted to get oxygen. We should give high flow of 100% oxygen, and is very successful treatment. And there are many drugs that we may in preventive treatment, so to diminish the severity of the symptoms. Among others, we may use capsaicin. And there was a study, there's one study which assessed capsaicin in cluster headache. The researchers used capsaicin versus placebo in the ipsilateral nostril for 7 days, and they observed patients for 15 days. In conclusion, headaches on days from 8 to 15, so after the treatment, were significantly less severe in the capsaicin group. And there's also a cis isomer of capsaicin, which is called capsaicin, which was also studied in cluster headache, but the number of patients was relatively slow, only 28%. Treatment period was 7 days, and the patients were observed for 20 days. Here we can show that the pain relief is greater in patients with treatment group, but the difference did not statistical significance. On the other hand, local adverse effects limited tolerability for some subjects. Because we use the capsaicin to the nostril, patients had nasal burning, pharyngitis, lacrimation, so which limited tolerability. And then the second channel, which is piezo2, inhibiting this receptor's function theoretically should block tactile allodynia without impacting protective nociceptors responses. Allodynia is a painful sensation without any noxious stimuli. So, for example, if you touch the patient and it is painful for them. And thus, piezo-2 antagonist should provide a new avenue for relieving a variety of chronic pain conditions. However, so far there are no studies on piezo-2 for clinical practice. Thank you very much for attention.
Okay, thank you very much for this presentation, and we saw some of the mechanisms that some connections between the physiology and the clinics, which I hope will be helpful to understand how important this discovery can be. It is important, and that it can be even more important. So, does anyone have any questions right now? I can start, but I saw someone like earlier, like thinking about making a question and asking a question. No? Okay. So my question then, if considering this mechanism and the TRPV channel, can it be also used somehow otherwise as the pharmacological site for binding maybe some analgesic drug in neuropathic pain or some other conditions? What do you? Okay.
I see such a possibility, and it is under research now. However, look at the point. It's the expression of these channels is really non-specific. They are involved, some of them are involved in development of cancer. So, what does it mean? That all this process of testing, of introduction into market will take time. Simply. It will take years. 2, 3, 5, 10. It is not easy. Capsaicin is well known. It's much easier. But this new, more selective agonist of some of these receptors or antagonist of some calcium or some sodium channels involved in thermosensation and also potassium channels, it will take time because we need to check how it will affect the whole body. Simply.
And that I think is the reason why we rather use topical agents than general drugs that we can take orally, for now, at least.
So you think it would be dangerous if all the channels all over the body got blocked at the same time? It would be.
But by the way, I'm not from this topic, by the way, but there are several papers published, also with and the team of Professor Julius and Pataputian. They extensively used some animal with knockouts. So this is quite good model because if they knock out one channel, one part of the channel, they can check what's going on. For instance, in some cases there was completely no sensation of pain. It seemed to be effective. However, the side effects, we need to wait. The first, what we see, it seemed to be effective, but the second, what's more?
Something else has come up, maybe? Okay, yes.
Does brain know from which part of the body the stimuli come? Because you said that we have receptors in almost every part of our body. For example, T or D are present in some parts. And does the brain know that the stimuli comes from arm, from brain, or lungs?
Probably in this matter, brain knows almost everything. In terms of thermoregulation, as a general process, what we know that in case of when it's colder, so when the temperature of the body goes down, or it's warmer when it's higher, some complex responses are produced with participation of autonomic nervous system. But this is the second. This is not the first response. This is the second. The first is behavioral response. If you feel it's colder, you are thinking where to go, what to wear on you, because in terms of bioenergetics, it's cheaper, simply. But to do that,